I still remember way at the beginning of my times in echocardiography when I was still learning, I was always attending my professor when he was reviewing studies. And he would be doing that from a video recording. At that time we did not have digital echocardiography. And he would be sitting there and doing these studies in fast-forward mode. And he would make diagnoses like hypokinesia or whatever, akinesia in even small segments. And I was always wondering, what is he actually doing? Is he guessing or what? Well, I guess he was guessing in a way, but he was making very good guesses actually. So he was right most of the time. In any case, what I learned was that the eye has to be trained to assess regional wall motion abnormalities. And this I will try to teach you. The title of this subchapter is actually not really adequate. In reality, when we're analyzing patients for coronary artery disease, we're looking for much more than wall motion abnormalities. We're looking for myocardial thickening, hinge points, the shape of the ventricle, and also the echogenicity of the myocardium. Even if the wall motion is not the only factor we look at, it's still a very important one. But let's take a look at the different degrees of wall motion abnormalities. This is a diagram which shows you the motion of the endocardial contour between diastole and systole. Here is an example of normokinesis, and this, in comparison, an example of excessive motion of the endocardial contour. We term this hyperkinesis. If motion is less than normal, but still there is some motion, we call it hypokinesis. If no motion is present, we call it akinesis. And if the motion is contrary, in other words, we have an outward motion during systole, then the patient has dyskinesis. Here are two examples. A patient with an anterior myocardial infarct. What do we see? Well, we see that the patient has akinesis of the apex. Important, there is motion, but this is only passive motion. There is no myocardial thickening here. So this is akinetic, the distal septum, and also the distal apex, distal lateral. We have hypokinesia in the border zone of the infarct, here in the mid-anterior septum, so somewhere in this region. And we also have hyperkinesis, which is compensatory in the mid and basal lateral wall. So when we look at regional wall motion abnormalities, we also have to look at comparison between different segments. And this is a very nice example which shows you that we have different degrees of wall motion abnormalities in one image, in one 4-chamber view. Here on the right-hand side, you see a patient who has an inferior infarct. This is the infarct here. What do we see? We see an abrupt change in the thickness of the myocardium. So this seems to be scar. We'll talk about the importance of scar later. And we see that there is no motion at all here, only passive motion caused by the motion of the mitral annulus, and the remaining part of the myocardium seems to contract normally. But let me go back a step because we need to understand the different conditions of perfusion: ischemia, necrosis, stunning, and hibernation. What are they, and how can we study them with echocardiography? These MO tracings are reproduced from a study performed by Sutherland, where he studied what happens if you occlude an artery in an animal model. The occluded artery was the right coronary artery, and what you see very early on is that we have hypokinesis of the inferior wall, but not only that, but we also have delayed contraction after aortic valve closure. This is also called post-systolic thickening. With further duration of occlusion, we have more and more hypokinesia until the segment is finally akinetic. If we reperfuse the segment, we see a thickening of the wall, which is caused by reperfusion edema. Can we actually see these changes in two-dimensional echocardiography? Yes, we can. This is a patient who was admitted to our hospital because of an acute inferior infarct. The patient went to angiography and the right coronary artery was reopened within 1.5 hours. What you nicely see is that the patient has akinesis here in the inferior basal, mid, and distal wall. And you can also see that the myocardium is very echogenic. Now, this echocardiogram was performed only 3 hours later after intervention, so this certainly cannot be fibrosis and it cannot be scar, but it is actually edema. So this echocardiogram nicely shows that we can study the different state of perfusion in these patients as well. Time is an important and crucial factor in the development of irreversible myocardial damage after acute coronary occlusion. It probably takes somewhere between 3 and 6 hours until the myocardium is entirely destroyed. What we then see is fibrosis and eventually scar tissue formation, but that takes approximately 5 to 6 weeks. So it takes some time until we see the typical pattern of a scarred infarct with echocardiography. So what other states of perfusion can we encounter? Stunning. Stunning is defined as a reversible reduction of function of heart contraction after reperfusion. In other words, we have a situation where the vessel was occluded and then reopened, but we do not have normal contraction simply because the myocardium is shocked or has some other form of damage done to it, but that damage is reversible. In other words, we can expect myocardial function to recover. So what do we see with echocardiography? A wall thickness that is normal, but hypocontractile or akinetic. And what about hibernating myocardium? Well, the definition is downregulated myocardial function to match chronic reduced blood flow. What do we have? We have a vessel which is completely occluded, but which didn't cause an infarct or only an infarct in a small region. The remaining region does not function anymore, but is not dead. In other words, it's sleeping, it's hibernating. Similar to stunning, we have no tissue damage and the myocardial function can still recover. We see the same thing in echocardiography as with stunning. We see a normal wall thickness, which shows hypokinesia or akinesia. This shows you the different states of perfusion and what happens to the corresponding myocardial segments. If perfusion is normal, we have a normal contractility of the myocardial segment with normal thickening. If there's a stenosis, however, perfusion is adequate, we also have normal contractility. If there's a stenosis and during exercise perfusion is not adequate, the patient develops hypokinesis, for example, during stress echocardiography. The wall thickness, however, is still normal. If the patient had an infarct, there is an occlusion, then there is akinesis and the wall is thin. If there's an occlusion which occurred slowly or there's some form of collateral flow, then there is hibernation. In other words, the patient did not have an infarct. The segment is still adequate with respect to its thickness, but hypokinetic. And very similar, if the patient had an infarct and the vessel was reopened, there is stunning. We also have a thick, normal thickness of the myocardium and hypokinesis. So if we look at the different segments with respect to their thickness and their contractility, we have ischemia, hibernation, and stunning, which show a very similar pattern, a thick or normal thickness of the myocardium and hypocontractility and sometimes akinesis. So these three different conditions are very difficult to differentiate with echocardiography. However, we can look at additional clinical findings and thereby elucidate what the problem must be. There are certainly other methods also in echocardiography with which we can differentiate these, for example with the help of dobutamine stress echocardiography. I would now like to introduce you to another very important concept, the concept of remodeling. Remodeling occurs after myocardial infarction and it is defined as progressive left ventricular dilatation where the patients eventually develop some form of eccentric left ventricular hypertrophy, but more importantly, develop a distorted left ventricle. Remodeling is so important because it influences the prognosis of patients and because it's so detrimental. Remodeling usually occurs in patients who have large infarcts. Therefore, it is also more common in patients who have anterior infarcts opposed to inferior infarcts. And it also occurs more frequently if the patients have an elevated afterload. In other words, if patients also have hypertension or aortic stenosis, they're at increased risk of developing left ventricular remodeling. This is probably also one of the main reasons why medications which reduce afterload, such as ACE inhibitors, are so effective after myocardial infarction. Patients with aneurysms are in particular prone to develop remodeled left ventricles. We haven't talked about aneurysms yet, because actually they are not a form of wall motion abnormality, but a form of deformation of the left ventricle. Basically, aneurysms are defined as an abnormal widening of all myocardial layers during diastole. So this is such an example of an aneurysm here. Conceptually, an aneurysm has a neck or a waist. However, the presence of an aneurysm does not necessarily mean that the patient has a severely distorted left ventricle. You can sometimes have very small aneurysms as well. In addition, some patients don't have aneurysms, but more severe forms of remodeled left ventricles. To explain this, take a look at this diagram. Let's say in the initial phase the patient has an infarct and he develops an aneurysm. The definition is quite clear. He has a neck and a widened apex, and all myocardial segments are involved. Then the ventricle starts to remodel, and what happens is he actually loses the waist, and then he also loses the aneurysm because he does not have the typical features of a widened apex anymore. So in the end phases, the patient has a situation where he is much worse off than in the initial phases where he only has the aneurysm. Keep this in mind when you perform echocardiography and you follow up patients with anterior myocardial infarction and aneurysms. We already talked about the different states of perfusion and that these states can be present in the same patient, in the same echocardiogram, or even the same view. Let's go through them now step by step. Transmural scar. What do we see? We see wall motion abnormalities, akinesia, dyskinesia, or aneurysm. And typically what we see is a thin myocardium which has bright echoes because it is a scar, because we see fibrosis. The myocardial scar does not have to be transmural. Very often we only see subendocardial scar, as you can see in this example. In this case, we still have residual contractile function. Therefore, the segment is not akinetic but only hypokinetic. The degree of dysfunction depends on how much scar tissue we have and how much residual myocardial function is still present. The thickness of the wall is usually normal or only mildly thinned. Sometimes we have transmural scar, but there is still residual myocardial function in the neighboring or adjacent segments. So we have dead and viable segments in close proximity to each other. In this case, we see akinesia and hypokinesia of the neighboring segments. Finally, we can have segments which are completely viable. We talked about that already, either during acute ischemia, during hibernation, or stunning. In this case, we see hypokinesia or akinesia, depending on the severity of stunning and viability, and a wall thickness which is still preserved. Or, in the case of patients of an acute infarct, we talked about that already, if edema is present, the wall is even thicker than normal. Now here are some examples so you understand what the full power and potential of echocardiography is. On the left-hand side is a patient who came in with unspecific chest pain where we were not sure what the patient really had. The ECG was not very conclusive and we thought the patient actually had myocarditis. But when we performed echocardiography, we immediately saw this regional wall motion abnormality. The entire apex is akinetic. The wall thickness is preserved. So that brought us to the suspicion of acute coronary syndrome, which was documented by coronary angiography, and the patient was adequately treated. Here we have a patient who had a myocardial infarction many years ago, and where we know that the right coronary artery is occluded. Now, we can certainly not expect that reperfusion will bring about a normal contractile function of the segment simply because it's a scar. It's thin, it's echogenic, and it is also aneurysmatic. This patient here is a patient who had acute coronary syndrome many years ago, but now he presented with dyspnea. Taking a look at the echocardiogram, you will note that the patient has a severely reduced left ventricular function, that the patient has regional wall motion abnormalities, but the function is more diffusely reduced. But interestingly, we can find a normal thickness of the septum. So there is suspicion that the patient has some form of residual myocardial function viability, and that was documented with other tests, and the patient eventually ended up having coronary bypass surgery, and he benefited significantly. Ventricular function improved after the procedure. And here we have an example of a patient who had an infarct 3 or 4 years ago, an anterior infarct, and the patient never had angiography at that time, but now he presented with typical anginal pain. We performed angiography and we found that the LAD was significantly stenosed, and since the patient had an echocardiogram with a preserved wall thickness and hypokinesia, we knew that it would make sense to really reopen or at least dilate or stent the vessel. So the key message here is that the echocardiogram provides very valuable information. If you put this together with the clinical information you have, it can really help you in managing patients with coronary artery disease. Quantification of left ventricular function is especially difficult in patients with coronary artery disease because you have to account for regional wall motion abnormalities. But in principle, you can use the following methods. The Simpson method. However, when you perform the Simpson method, you have to be aware that you're doing that in a 4-chamber view, and if you also do the biplane method, in a 2-chamber view. But you're not doing it in a 3-chamber view. Therefore, wall motion abnormalities seen in the 3-chamber view, in other words, the posterolateral region and the anterior septum, is not included in this calculation. So you can over or underestimate left ventricular function based on where the regional wall motion abnormalities are. I personally prefer visual assessment of global left ventricular function in these patients, where you kind of take a look at the ventricle as a whole and where you try to look at the regions or the amount of segments which are involved, and also how the contractility of the remaining myocardium is, to come to an estimate. Now this certainly needs a lot of experience, but honestly I still believe that this method is probably more exact than just calculating ejection fraction by the Simpson method, or by using other techniques which have been proposed, such as the wall motion scoring technique or the centerline technique. I don't want to go into too many details about these two techniques because they're not very well established, and actually nobody really uses them in clinical practice anyway. But what I do believe will have a future are the so-called 3D methods. This is an example, a 3D study in a patient with a left ventricular aneurysm. After contouring the left ventricle, what we get are these so-called pumping bags, which allow us to calculate left ventricular function, not only globally, but also the regional function based on the individual segments. You can see different colors for different segments, and these also correspond to these volume curves. So this is a very nice way at really looking at global left ventricular function in the setting of regional wall motion abnormalities, because now you're really considering all segments. In this specific example, you can see that wall motion is reduced in the region of the aneurysm. Just to summarize, 2 key points when you quantify left ventricular function in the setting of coronary artery disease. When you perform the Simpson method, remember the 3-chamber view is not considered, so wall motion abnormalities in the posterolateral and in the anterior septum are not in the calculation. And when you perform visual assessment of global function, don't forget that other segments can also be hypercontractile, as in this example of a patient who had an inferior infarct, acute infarct here in the inferior wall, where the remaining myocardium is hypercontractile. This is compensatory, and if you look at global left ventricular function just based on this view, he has normal left ventricular function despite the fact that he has regional wall motion abnormalities. Unfortunately, it's not always easy to really detect wall motion abnormalities and to see the endocardium, especially in patients who have poor image quality. Now this is such an example where we do not really see the lateral segments, apical and mid segments, and where we do not know if a wall motion abnormality is present. Now in these patients, what we can use is left ventricular contrast agents. This is such an example. We injected this agent and it opacifies the left ventricle, and we can now really delineate the endocardium very nicely. In this patient, we see that there is hypokinesia in the apical wall. So left ventricular contrast agents are very helpful in the setting of patients who are difficult to image and truly enhance our ability to detect regional wall motion abnormalities. You will hear more about contrast agents in our chapter on other techniques. Here you see the three different regions which I believe are most difficult actually to interpret: supraapical, lateral, and basal inferior. Here you can see what you can do to improve your assessment of these regions. For the supraapical region, try to avoid foreshortening. Move the transducer more lateral and image towards the apex. And in particular, use the two-chamber view because we have less foreshortening. For the lateral region, try to rotate the four-chamber view more clockwise towards the posterolateral wall. Move the transducer more medial and thereby have a better perpendicular angulation towards the lateral wall and thereby a better resolution. And for the basal inferior region, try to assess how motion actually is. Is it more passive or active? Look for hinge points and also try to see if the wall thickness is normal or not. There are a number of conditions which can mimic coronary artery disease, either because there is a regional wall motion abnormality due to another cause, or because it appears as if the patient has a regional wall motion abnormality. This is the case, for example, in patients who have dysynchrony. Dysynchrony is usually the result of a left bundle branch block or pacemaker. This is an example of a patient with left bundle branch block. And if you look at the apex or the apical segments, you might have the impression that the patient has regional wall motion abnormalities there. However, the septum is just asynchronous and biphasic. Other forms of abnormal septal motion can also mimic coronary artery disease, for example, in patients who have pressure or volume overload of the right ventricle. Patients with myocarditis not infrequently also have segmental involvement of infection and thereby also regional wall motion abnormalities. So this makes it in particular difficult sometimes to differentiate acute coronary syndromes from acute myocarditis. And finally, as already discussed in the chapter on cardiomyopathy, even patients with dilated cardiomyopathy have some segmental differences with respect to contractility. Very often it's the posterolateral wall and the lateral wall which functions better than the rest of the myocardium. Another cardiac disease entity which is associated with regional wall motion abnormalities is the so-called Takotsubo cardiomyopathy. Just for review, Takotsubo is defined as a transient left ventricular apical dysfunction associated with apical ballooning and T-wave inversions of the ECG. It is also called stress cardiomyopathy because it's associated with elevated catecholamines and, importantly, no coronary obstruction. Here's an example of a Takotsubo cardiomyopathy. If you look at the four-chamber view, you can see that there is a wall motion abnormality of the entire apex. So just looking at the echocardiogram, you would probably assume that the patient has LAD or proximal LAD occlusion. However, the coronary arteries were completely normal. Note that there is also a thrombus within the left ventricle. So you see, wall motion abnormalities is a very complex issue. And keep in mind, it's not only hypo A or whatever dyskinesia, but there's much, much more. Think of all the factors and about the physiology behind it. And very important, always put yourself in the driving seat of the referring physician and the patient, of course, to get the most out of the exam and to answer the questions which are relevant.